Everybody hear me? Distance sides, can you guys hear me? Okay, I got a thumbs up. I got this one. Thank you guys. Just something quick before Dr. Tubog starts. Some of you might have already seen the announcement. I neglected to tell you guys, and most of you are probably well abreast of when holidays are, right, because you're a student. But next Monday is Memorial Day. Hope everybody remembers that. There's an announcement. So, come here if you wish, but you might be alone. All right? Just want to make sure you guys know that there's no class on Monday, the 27th. It's also on your syllabus. Thank you.
Don't come here on Monday.
Well, some people drive and they may forget. Then you drive in and you're like, crap.
Yeah, it's
Memorial Day.
We're going to take it out. It's Memorial Day.
And thank you to those who have served our country.
Oh, yes.
Although that's Veterans Day, really, because you're still alive, thank God. Okay, have a good lecture. Have a good lecture. Did you know the difference?
I did.
Okay.
Well, me, ESL.
Is there a Memorial Day in the Philippines?
Yes, we do. We do actually July 4th. I know you're in our independence here. Kid, can I start? Because we're gonna try to have fun this afternoon. You look so tired, guys. You guys are tired. I know the 5 days is coming up. Kid, can I start? Is that a yes or a no? Yes. Yeah, okay, yeah, but I want to make sure it's recorded. Okay, gotcha. Sorry. I know you look tired. I was watching you guys in the screen. Work you up. The good thing about it is it's a skill. We're talking about a skill that you guys need to have. Now, all of you, before you graduate, are going to be able to do spinal and epidural. Now, when you graduate, that's another story. There are hospitals or there are organizations that don't allow CRNAs to do epidural and spinal. So if you work in that environment, you may not be able to do spinal epidural at all after graduation. But if you're going to be working in a facility we're in, they have you guys do spinal and epidural for your patients, then this is one of the skills that you're going to be doing for the rest of your life. Spinal anesthesia, it's like inserting an IV. Well, I'm going to relate it to inserting an IV because it's in terms of the skill level, it's not as hard as epidural anesthesia. Epidural anesthesia requires a little finesse, requires a little architecture in it. You have to be very, how do you call it? Your psychomotor skills should be very in tune when you do epidural anesthesia because there are other complications associated with epidural anesthesia. There are additional steps that you have to go compared to when you do a spinal anesthesia. You stick the needle in, go into the ligaments until you reach the subarachnoid space, and you know you're there, just like when you start an IV, because in an IV we see blood coming out, right? As long as it's not pulsating blood, because therefore you're doing a radial A, or you're doing an A line at that time, right? In spinal anesthesia, you know you're there because you have this clear liquid coming out of the needle. You know you're in the CSF, and then you can put your local anesthetic in there, and you start your surgery. So today we're going to do spinal anesthesia, and then on Wednesday we're going to do the epidural. A patient of mine called it epidermal one time and said, "Hey, Tito, can I have my epidermal already?" So every now and then I joke a lot. I would say, "I'll start your epidermal," and then some of the patients say, "Oh, I thought it's called epidural." So you'll hear me say if epidermal, it's because of a reference to one of my patients. She's a very lovely lady, as a matter of fact. And I told her, I said, "I think we call it epidural." And she's like, "Oh no, I thought it's epidermal." It's kind of like recovery nurses would call propofol as prototol. Have you heard about that? They call it, "Hey, can you give some prototol?" I'm like, "Yes, I can give some prototol." It's actually propofol. So every now and then I usually tell them, "Hey, we call it propofol. It's not prototol." But it's one way to re-educate our fellow interdisciplinary team. Remember, we're going to be working, you guys are going to be working in a team. And guess who's the leader of that team? You are the leader of that team. So you need to be able to express yourself as a leader of that particular team, and you need to be able to stand with your 2 feet. It's okay to call for help. It's not a weakness to call for help. If you feel like you're in trouble or you feel that trouble is about to happen and you don't know how to troubleshoot it, call for help. It's not a sign of weakness when you call for help. Don't think of anything like that, because I know a couple of years ago when we were training, we were told if you call for help, it's a sign of weakness. It's not. As a matter of fact, it's a sign of strength because you know your limitations. Okay? So let's start with spinal anesthesia today. I hope this is going to work. And let me make sure the pen, oh, no. I want to make sure the pen works. Hold on. Why is it not? Sorry. See, it's not a sign of weakness. Sorry. Again, why is my pen? See, it keeps on. Yeah.
Oh, yeah.
Terry was able to write that stuff earlier. Okay, I guess I'll just have to write. What is this? Okay. While he's fixing it, what we're going to do today is we're going to understand the physiology of spinal anesthesia. So in other words, subarachnoid block or intrathecal block. We're also going to look at landmarks because that's what you need to know when you do spinal anesthesia. You need to know where the landmarks are. There are certain parts of the body that you can't do spinal anesthesia, i.e. anything where the spinal cord is, right? Because we don't want to create any paralysis of the patient. And then we're going to look at technique. Now, each of you are going to do your own simulation of the spinal anesthesia in the simulation lab. A couple of years ago, I tried to demonstrate it here, but a lot of our distance site students cannot see. It's working. Okay, so I'm gonna show you how to do the spinal anesthesia, the technique-wise, and then we're gonna look at troubleshooting techniques. Because every now and then you're in a hurry, you set the patient up, or you put the patient in a lateral position, and then when you stick the needle in, all of a sudden you felt a bone, a periosteum, and you're like, oh, where am I? Because we don't have an X-ray vision, right? We're not Superman. We can't see where our needles are going. What we do is we go by feel. As we put that needle in the patient's back, we go by feel. And we want to make sure that we're going where we are supposed to go, because if we hit his name is spinal cord. If we hit him, he's not gonna like us. He's not gonna like you. He's not gonna like us. And a couple of years later, they're gonna call you and they say, hey, what happened during the day? We don't wanna be in that situation, okay? So when we talk about spinal anesthesia, so this is the injection of the local anesthetic. So you learned local anesthetics last semester. Injection of the local anesthetics in the subarachnoid space. That's the reason. So it's subarachnoid space, okay? So you inject your local anesthetics in the subarachnoid space. That's the reason why it's called subarachnoid block. Or we put the local anesthetic in the thecal area. That's the reason why we call it an intrathecal block. So they're the same. They're synonymous. Intrathecal, subarachnoid, spinal anesthesia are the same. Now, it can be used as a sole anesthetic. When I say sole anesthetic, there's no other anesthetic involved. So hip replacement, C-section, knee replacement, anything from here, from the actually upper abdomen level going down, you can do a spinal anesthesia. Or you can use it in combination with a general anesthesia. Okay, so it can either be both. And how does it work? Well, the way spinal anesthesia works is when you put the local anesthetic in the subarachnoid space, the idea is wherever that local anesthetic in the subarachnoid space is going to touch, it's going to cause some dense block. When I say dense block, we mostly refer to the block as sensory block. Does a motor block occur? Does autonomic block occur? Yes, they do. But mostly when we talk about surgical procedures and we do spinal anesthesia, we refer to the sensory blockade. Now I'm going to say this again. Motor blockade and your autonomic nervous system blockade also occurs with your sensory blockade. Now, the effects of that local anesthetic depends on the size and the myelin content of the nerve fibers. Okay? Those fibers, nerve fibers that are myelinated, tend to be the one that gets numb first. And those nerve fibers that are smaller in diameter tends to get that numbing medicine first than the larger fiber. And we're going to talk about that as we go along in our lecture. Okay? Now, the higher the concentration, it makes sense, right? The higher the concentration is, the faster the onset of the block, right? So if I asked you 0.0625 versus 3%, which one works faster? The 0.0625% or the 3%? 3%, right? Because its concentration is bigger, right? The concentration is bigger. And then there is such thing as the duration of contact between the nerve root and the local anesthetic. So, remember in your pharmacology, Dr. King talked to you guys about vasoconstrictors when you add in a local anesthetics, for that local anesthetic to stay in place for a longer period of time, because that vasoconstriction prevents reabsorption of the local anesthetics. That's what I meant here. So the more you put a little additive in your local anesthetics, when you put it in the subarachnoid space, the more numb the patient is, or the more the numbness stays longer. So vasoconstrictors makes that time of the numbing or the blockade a little longer, whereas opioids make it very intense, like it's very solid. Like if you look at numbness, let's say 0 as not numb and 10 as very numb. If you just use a plain local anesthetic, perhaps your numbness would be at 7. But if you put a little bit of morphine or a little bit of fentanyl in there, or sufentanil in there, your numbness will be classified as 10. So get what I mean? The local anesthetic with opioid, the sensory blockade is very intensified, whereas vasoconstrictors, the duration of that numbness, of that blockade is a little longer than without a vasoconstrictor. Okay? So we're clear on that. Okay, so this is the other terms that I said earlier. So if there is a delay, Houston, we have a problem with you now. Okay, so it's called intrathecal, subarachnoid, anything from the abdomen lower, we can do spinal anesthesia. This is the preferred anesthetic technique. This is the preferred anesthetic technique for cesarean section because of low morbidity and mortality. Can you do cesarean section with general anesthesia? Yes, you can, right? Yes, you can. Emergency section, or sometimes if, well, it's going to be emergency section, not a stat C-section. We're going to talk about that later. But emergency C-section is you do general anesthesia. Why do you think general anesthesia can do harm to the baby? The drugs that you learn in Pharm 2 crosses the placenta, right? Crosses the placenta. So if, let's say, you use opioid, right, during general anesthesia, which we will tell you, we're gonna teach you how to do C-section in a couple of lectures, not in this class and not in this lecture. But you rarely use opioid during C-section. You probably would use a little bit. You probably can use some of the gas. Of course, you need to use the gases. But they can travel or they can cross the placenta and it can harm the baby. Now, what happens when we do general anesthesia? What happens to the hemodynamics? When I say hemodynamics, blood pressure, what happens? It goes down with it, right? So do you guys know, or you guys probably know that the amount of blood that the fetus get depends upon the blood pressure of the mother, right? So if the blood pressure of the mother is low, there is not enough oxygen going to the baby because there is not enough blood going to the baby. Guess what happens to the baby? The baby is not going to be good. Your APGAR score, so APGAR score is measured in 1 minute and 5 minutes, right? Remember that in nursing school? Your APGAR score will probably be like 4 or 5. Not good. Therefore, you have uteroplacental insufficiency because of hemodynamic instability of the mother. That's the reason why the baby is not doing well coming out. Now, is that going to be a problem? Yes, it's going to be a problem, but guys, your priority is the mother. When you're in the OR doing a C-section, your priority is the mother. There is going to be a neonatologist taking care of the baby. Unless they have a hard time intubating the baby, your mom is the priority. If they have a hard time intubating the baby or maintaining airway, they're probably going to ask you for help. Now, do not leave the mother. So this is where you call for another backup. Because if something happens to the mother, that's our liability. Okay? Okay. Contraindications, we talked about it. Patient's refusal is the #1 contraindication. Increased intracranial pressure, active coagulation if the patient is bleeding. You don't want to stick somebody's back. Because there is a tendency, that needle that we're going to use, so the needle that you're going to use is very small. I'm gonna open this later. This is usually the needle that you're gonna use. It's a 25 gauge. Remember 25 gauge? It's the same as your IV needle. 25 gauge is very, very tiny. Even that tiny needle can cause a hematoma. So you don't want to stick somebody who's actively bleeding. And patients who is unable to position himself or herself. If you have a mom or a patient who's very mobile, so if they're sitting at the side of the bed, every time you put that needle in, they do like this, and they do like that, and then they're going off the bed. Or if they're on the lateral position, they do like this. You can't put that needle in a moving target. It's really hard. You have to explain them up to the mother. In order for me to put this needle safely in your back, talk to them face to face, eye to eye. You need to be still, or else I'm not going to do it. And usually that conversation with the patient usually will cement in their head, and usually they're like, I just need somebody to hold me so that I don't move around. You don't want that. Now, relative contraindications. So when I say relative, depending on the factors. systemic infection. If the patient is already taking massive antibiotics, and if spinal anesthesia is the only way to do the surgery, i.e., if I put you to sleep, you're gonna die, then you can do this, right? Hemodynamic profiles. Now, I have to caution you guys, patients who are hemodynamically unstable, if there is an option to do general anesthesia, go for it. A perfect example, if the patient has aortic stenosis, we talked about it in our previous class. So when you put your local anesthetic, you're gonna have CV changes. We're gonna talk about that. That severe hypotension that occurs with spinal blockade is gonna be very difficult for a patient who has aortic stenosis. Remember, in aortic stenosis, we don't want their SVR to be low, right? We want it to be high. The moment it goes down, we circular the drain. Remember that spiral that we talked about? That's what's gonna happen to your patient. So be very careful on aortic stenosis patient. Severe hypovolemia, again, that can be treated, right? You can give fluids before you start the procedure. We actually do. You can give crystalloids before you start the procedure. We actually can do that. So those are relative contraindications. What are the advantages of spinal anesthesia? Oh man, there's so many. But I'm just gonna put here something that you can verbally ask you in your training starting this August. Big time. Decrease incidence of thromboembolism. That's big time. Remember they do that SCD hoses and that compression device? We still do, but spinal anesthesia can reduce that big time too, the thromboembolism. Decrease cardiac morbidity and death because of the adverse hemodynamic effect. Because of the adverse hemodynamic effects of general anesthesia. You're gonna see this this August, on your first day, let's say on Monday. I know you remember 2 milligrams per kilo for propofol. You're gonna notice that we don't really give that 2 milligrams all in all. We give slowly until we see the effect. Because guess what? Hemodynamic instability on that patient, I can tell you right, you start your gas, everything is gonna go down. It's gonna be very exciting for you because you're gonna see it for the first time that Monday. And you're like, oh my God, I can do this, I can do this, I can do this. That's what Dr. Kane was saying. Next year, same time next year, because we're gonna see each other again next year in another capacity because we're reviewing for the boards. And you guys are gonna be here, like you guys are tired right now. Next year, you're gonna be more tired, right? You're gonna be more tired because you didn't have a break. You know, the second year students didn't have a break, that 5-day break. They were in the OR the whole time. So you're gonna be, can we not have a class? Can we not have we need to have a class because we need to pass the boards. Reduce risk of bleeding. So I guess I have to go lower, right? So in order for us to know how to do spinal anesthesia, we need to know this basic anatomy. And we're going to run through these very quick because this is just anatomy. So the first thing we need to do, okay? So we need to know spinal columns, right? We need to know the spinal nerves, and we need to know where the spinal cord ends because that's our enemy. Mr. Spinal Cord is there, lying, and he's like, looking at the needle. Is it coming towards me? Right? We need to make sure that we're not, please guys, do not, for Christ, do not hit that spinal cord. Do not. So I'm going to teach you how not to hit it. Okay? Not to hit it. Okay. How many vertebrae do we have? We have 33, right? Remember that? Oh, shoot. How do you write this? 33. 33 vertebrae, right? We have 7 cervical, 12 thoracic, 5 lumbar, so 5 lumbar, 5 sacral, and 4 coccygeal, or how do I pronounce that in a nice way? Coccygeal. I have a friend who pronounces it as coccyx. She would like, hey Tito, where's the coccyx? I'm like, huh? I've never heard of the term coccyx. But, so 33 all in all, 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal, right? But we have only 31 nerves. Remember that. We only have 31 nerves. Remember that with Schmidt? So the nerves are 8 cervical, right? 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Okay? Okay. We're agreeing to that. So we know that C1 is our atlas and C2 is our axis, right? Remember that, right? The conus medullaris end in L2, right? That's where your cauda equina, right? So conus medullaris ends in L2, and we're gonna talk about the spinal cord in a few slides from now. Okay? So those are the basic, and whether you like it or not, whoever is gonna be working with you, and you're gonna start spinal, Harlingen. Who are going to Harlingen? Okay, you're going to be doing spinals like the moment you start there. They're going to be asking you questions about anatomy of the spine. I can tell you right now. So they're gonna ask you how many this, how many that, la la la. You need to be able to boom, 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 boom. Okay. Now let's say you boom, 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 and then you're not sure with the other one. Say, I will look for that answer. And when I see you again tomorrow, I'll tell you where it is or what it is. Do not just say, I don't know the answer. Don't say it like that. I said, I remember it was taught in class or I saw it somewhere, but I can't remember it right now because everybody's asking a question over here, la 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 la, right? And you can't concentrate on like, am I there, am I there? And like they're asking you, so where is conus medullaris? And then you're like, am I there? Like, you're doing your spinal in there, you're inserting a needle, but they're asking, where's conus medullaris? Right? So, answer in a nice way, say that, hey, I remembered, I read it somewhere, but I'll tell you tomorrow. Okay, so, I'll tell you tomorrow. And don't forget to come back so that you get cool points. Okay, this pen doesn't work. Okay, let me try if I change. Oh, see, it's not. Okay, what I want you guys to remember in this figure, who messed this up? Okay, so I hope I'm going to encircle it under line. This one, it's supposed to be T7. Go to the, so they always want to ask, I don't know why. What level is the inferior angle of the scapula? It's actually because of thoracic epidural, but we'll go there. Our lecture is next Wednesday. But, okay, so let me see if I can do it. Okay, so inferior angle of the scapula, T7. Remember that. The superior aspects of the iliac crest, because if I'm going to write, it's going to go everywhere. You see that says L4? See that says L4? Remember that because that's where going to be our landmark when we do our spinal anesthesia. So the superior aspects of the iliac crest is located in L4. So L4 meaning to say the body of L4, right? Some would say, what interspace? Your answer should be the interspace between L4 and L5. But if they don't ask for the interspace, the correct answer is for the superior iliac crest it's L4. Okay, L4. Okay. How many of you have seen caudal anesthesia? Kids, isn't it amazing? After I graduated, I haven't done this because we do this a lot for kids. So caudal anesthesia. So this is the thing that I want you guys to remember. The sacral cornu, I can't underline it, but sacral cornu, oh my God, it went down. The sacral cornu are those bony prominences. This is going to be difficult, Ken. The sacral cornu are the bony prominences, and in the middle of it, can I borrow a pen? And in the middle of it, I just want to cry. It's like, the stuff over here is gone.
It's okay.
Do you have a paper?
How about the
say
mouse?
the word. Huh? You can draw with the mouse? I can draw with the mouse? Oh. Can I? Okay. And then okay. Okay, this is even better. Okay. Oh, man, thank you. I was about to cry.
You want to use the iPad?
Oh, you're asking the wrong person. Okay, so, okay. Oh, thank you. There's no crying in anesthesia, right? I was just gonna go to the bathroom and cry. To a point of. Okay, so, I need my glasses. So the cornu are this kind of like, it's kind of like bone, because we're adults, so we can't feel our bones anymore. But for kids, you're gonna feel this little bitty bump. So that's your landmark because that's the bone. And then the hiatus, so I wish I have the doll here, the mannequin. So the bone is on the bilateral, and when you put your finger at the middle of these two bones, you're gonna feel an indentation. You're gonna feel an indentation. That's your sacral hiatus. That's where, so sacral hiatus, that's where you put your local anesthetic. And Dan Ernst is going to talk to you guys about how to do that because he's a pediatric CRNA. So you put your local anesthetic in the sacral hiatus, and caudal anesthesia is not a spinal anesthesia. It is an epidural anesthesia. Okay? So caudal anesthesia is an epidural anesthesia because you put your local anesthetics in the epidural space. Okay? So the epidural, so if somebody's gonna ask you this, the epidural starts at the foramen magnum. Starts at the foramen magnum, so this is starts. And then it ends in the sacral hiatus. Okay? So most of the time we do this for, of course, GUT cases, genitourinary cases, like for pediatric populations. Now when you go to your pediatric training, every now and then you're gonna see this. Can I keep some of it? And then I'll give it back. Yeah, thank you. Thank you. Oh, you need to write on it.
I have them here.
You have them? Okay, thank you. Okay. So, thank you so much. That prevents me from crying. You don't want me to cry because I don't sound right when I cry. So, why am I putting the word high and low points in the picture? The reason why I'm going to put that there is because you need to know where your local anesthetics are going to go when you put it in the site. So I'm going to use the figure again over here. So I'm going to change this. I'm going to do it the same Dr. Rick, you would do this before. So in this picture, this is the local anesthetic sites. Now it's just telling us that if you put the patient on his back, so after you put that, so let's say you put the spinal anesthesia sitting, the patient sitting on the side of the bed or on the lateral position on the side of the bed. After you do that, we call it spinal induction, you put the patient to supine position, right? So once you put the patient supine position, these are the areas where we consider the highs and the lows. So for the low part, so let's go in the low part. If you go to cephalad, the lowest portion is T6, right? If you go to the sacral area, the lowest portion is S2. Why is that important? You guys talk about veracity in your local anesthetics already? Okay, great. If it's hyperbaric, it tends to settle down, right? It submerges based on gravity, right? Hyperbaric solution, right? Isobaric stays where it is. Hyperbaric flows. Remember that? Remember that? Okay, so if you have a local anesthetics that is a hyperbaric, so therefore it's gravity dependent, right? So if you put the patient flat on his back, those local anesthetics are going to settle in two areas, or is the lower areas. So one is going to go to T6 if you put it over here, or it's going to go to S2. That's the reason why majority of the local anesthetics that we use are hyperbaric solution. That's the reason why every time we put the patient to his back, your blood pressure and your heart rate starts to go down. Why do you think? It says T6. That's the lowest. When you go higher than T6, what is it? T5, right? Higher than T5. T4. Higher than T4. T3, T2, T1. What did we talk about T1 and T4? What is that? Your cardio accelerator nerves. So guess what? You know your spinal anesthesia is working when you put the patient flat on bed and all of a sudden your blood pressure gradually starts to go down because that local anesthetic is climbing up to the cardio accelerator nerve. Okay? Now, the highest portion, now this is only true with hyperbaric because they float, right? So the highest portion, if you go cephalad, it's C3. If you go caudate, it's L3. But I can tell you guys, most of the time, you're going to see this because your local anesthetics are most of the time, not always, but most of the time, are hyperbaric solutions. So when they tell you, is your spinal anesthesia already works, the only thing you need to do is listen to your blood pressure. Listen to your heart rate. So if you started with 80, let's say 85 heart rate, when you put the patient on his back and you start kind of like making sure that his arms are already tied so that they can't move and stuff like that, if that heart rate starts going down to 80, 75, 7, you know your spinal anesthesia is working. Okay? Okay. Let's go back to the screen. There you go. The orientation of the so you know what spinous processes are, right? Really. Even the back is gone. Where is the back? I thought we have a back here. They got rid of it too?
Well, we got new carpet.
They know I'm doing spinal. Okay. Okay, so you know what spinal processes are, right? The ting that comes out. Okay. So oh, it's here. Thank you. I really thank this. Okay. So the lumbar spinal process tends to be horizontal and to be like this, whereas the thoracic tends to be like this. The thoracic is oblique. So what is the clinical implications for that though? So if you look at, you know what, it's also known as this. It's okay, skinny needle, right? Okay. Oh. So you can see. Okay. Oh, goodness. Okay. So this is the loom. I'm about to yell. So this is the lumbar area. So if I'm gonna insert a needle, I'm gonna go as horizontal as possible, right? But if I'm gonna start an epidural, because you can't start spinal on thoracic, because guess what? Why do you think you can't do spinal in the thoracic area? The cord is there, he's waiting. I'm here, I'm very big here, right? So when you do an epidural anesthesia, you go like this. Your orientation of the needle is like this, it's also oblique. That's the clinical implications of those spinal processes. When you start your spinal in the lumbar area, you go straight like this. When you do an epidural in the thoracic, your orientation of your needle is oblique. Okay? So that's why I put there, because they will ask you that in OR. Okay. Blood vessels. So every now and then, because there's so many things going on in the OR, when you insert the needle in the patient's back, instead of getting CSF, you get a lot of blood. Okay, so that only tells us that the blood vessels, you hit the blood vessels, because the blood vessels in the spinal area are usually in the lateral positions. They're usually located lateral position. So if you insert the needle, ching, 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 and then all of a sudden you remove the stylet and you see blood, it's like, I'm blood, hello. And you know it's blood because it's red, right? Right? And it's continue like going there, ching, 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 it doesn't stop. Therefore, you're in the lateral side. You're not in the right space. Pull that needle out and start over again. Okay? Pull that needle out and start over again. Because you're not going to hit your subarachnoid space. You're never going to hit that. Because therefore, you are in the lateral portion. The lateral portion. Let's see if I can show this. Instead of at the middle, you were going on the lateral side. You're never going to hit your subarachnoid space that way. Okay? Okay. Another anatomy, ligaments. Okay? So as you could see, you have 1, 2, 3, 4 single ligaments. Favorite of everybody, because I think it's the name, ligamentum flavum. Can we name the dog, Amanda, ligamentum flavum? Yeah, we can name another dog ligamentum flavum. But you have 1, 2, 3, 4, 5. Now, very curious here, your anterior and your posterior are to the front of the patient. So this is the front of the patient. This is the back of the patient. Right? So guess what? Which of these ligaments you're not going to traverse when you put your needle? The two that you're not going to hit. Because if you hit these two, madam or guys, you went through and through. Right? You went through and through. Right? So the only ligaments that you're going to traverse when you put your needle, it doesn't matter whether it's a spinal anesthesia or an epidural anesthesia, are this ligament. The first one you're going to go is the one on top, supraspinous ligament. It's a little thick. Interspinous ligament is one of the ligaments that's easy to go through. Oh, it feels so good. It's kind of like a marshmallow. Like, gee, you just, you go like that. And then by the time you hit this yellow, the reason why it's colored yellow because apparently per autopsy, the ligamentum flavum is always yellow. So by the time you reach the ligamentum flavum, it feels like if you have hair, because all of you have hair, right? Not like Coons and Nate. If you do this in your hair, if you can feel that or you can hear that, when you traverse the ligamentum flavum, that's how it feels like. It's gritty. It's like as if you're sticking something in a sand. It feels like this. So you know you're almost there. You're like, yes, I'm there. Because the next one is subarachnoid space. Boom, I'm there. So a lot of the students, even practicing CRNA, they know that they're in the right track when they start feeling this one. And they're like, okay, few more, boom, there you go, boom. You can feel the pop. You probably heard of that, say that. You're gonna feel the pop. Even me, even though I'm not doing it, I can feel it, I can hear it a little bit. But you, the person doing the spinal, you're gonna feel the, you're like, boom, you're there. And don't get excited, just like intubation, make sure everything is, roll the needle, or move the needle out. So, 5 ligaments, 2 ligaments you're not going to be traversing when you put a spinal or an epidural anesthesia. The rest of them you will, depending on the approach, depending on whether it's a median approach or a paramedian approach. Okay? Okay. Now, in terms of the distance, and this is just based on some studies out there, it's variable when you have your patients in front of you. 50% of the patient, the distance from the skin to the ligamentum flavum is actually 4 centimeters, and of course, 80% around 4 to 6 centimeters. And as you could see in terms of the thickness of the ligamentum flavum, the lower you go, the more you go caudally, it gets thicker and thicker. Now, why am I saying this? So that when you start practicing clinical training, when you have a patient, think of 4 centimeters. Now, when I say that, not everybody will be 4 centimeters. So not everybody will be 4 centimeters. You have somebody who is a BMI of 15, maybe only around 4 or 5. You think it's going to be because it's thicker, right? You're going to be a little bit further. But then you have somebody who's very skinny, and all of a sudden you're like 4. Like, oh, it's not there. You keep going, it's not there. You're like, am I in the middle? So you move backward. You're like, am I in the middle? Yeah, you're in the middle. You keep going, it's not there. You're like, where am I? Right? And then by the time you reach around 6 or 8 or 7, all of a sudden you hear this loss of resistance. I'm like, oh, wow. You did expect that for a skinny patient because 40% of them are only 4 cm and around 4 to 6, 80% of the patient from the skin to the ligamentum flavum. It gives you an idea how deep you want to go. Now, these are studies, variability on your patient. Like I said, most of the time, morbidly obese patient, you will need longer needle. I don't have a longer needle here. You will need longer than this one to go to the subarachnoid space. Sometimes very long to go there. Good luck if you have a needle in the hospital like that. But sometimes what you could do is once you go to the skin, you just push a little further until you go there and keep your hand in this needle so that it doesn't go away. Okay? Okay. Now we go to the spinal cord. Put this in your note. L1 is the end of the spinal cord for adult, and L3 the end of the spinal cord for children. L1 and L3. Now, I'm showing a picture here that at some point there are differences. I don't know if you notice here. T12. There are some patients, the spinal cord ends in T12. Now, why am I saying L1 for adult? I want you guys to be very safe when you start practicing. You can be aggressive when you become a CRNA, but when you start training, just remember it's L1, because you guys are not gonna, so the end of the spinal cord is L1, you're not gonna put your needle in L1. You're gonna go lower than L1, because we're still learning. Once you do spinal at least 10, 20 times, you know where it is. You can navigate it, but once you're learning, remember it's L1 is your adult, the spinal cord ends, and then when you inject your needle, it still should be lower than L1. Don't go at L1. It's very risky. We have insurance for you, but it's still very risky. Go lower, because I can tell you, they'll tell you to go lower, okay? Let's have 10-minute break. Sorry. Your spinous process, this is the first layer of your ligament. It just tells you guys where, so as you notice, this is the ligamentum flavor. I wish it's colored yellow, but it's not. And near that would be your epidural space. So we will talk about the epidural space this Wednesday. Today we will focus on the subarachnoid space. That's where we're going to deposit the local anesthetics, okay? So another review is the meninges. There are 3 spinal meninges. The first one is the dura. We know it's very thick. It's the outermost layer, and it starts at the foramen magnum and ends at S2, where it fuses in the filum terminale. So your dural sac ends in S2. And then the next one, which is for us the most important when we talk about spinal anesthesia, is the divisions between arachnoid matter and the pia mater, because that's where the subarachnoid space is. So the subarachnoid space is between the arachnoid matter and the pia mater, and that's where we're going to deposit the local anesthetic. The good thing about the subarachnoid space is, compared to an epidural space, the subarachnoid space has CSF in it. So once you hit that space, it doesn't matter whether it's on the side or on the middle or on the other side. It doesn't matter where you hit it, towards the right side or median or towards the left side. As long as you're inside that subarachnoid space, you're going to get a CSF. Now, we will talk about some troubleshooting techniques, because sometimes when you put the needle in, you felt the pop and then you stop, but you're in between the subarachnoid space and arachnoid matter. Sometimes you don't get a CSF flow. I'm going to teach you a technique, and we're going to teach you that in your simulation lab. Sometimes you just turn your needle clockwise until you get that CSF flow, okay? And then you can inject your local anesthetics for that. So those are some of the techniques, and we're going to talk about it towards the end. So the arachnoid matter is avascular, thank goodness, right? Because we don't want to put a bupivacaine in an IV, right? In a vein, right? So we don't want to do that, but it's avascular. Whereas the pia mater is a very thin connective tissues that has collagen in it. So those are the three major spinal lineages that we have. Now, whatever they tell you about CSF, it's CSF, it has to be clear, okay? It can't be cloudy.
Dr. Tubog, I'm not sure if lecture started again, but the distance sites, we can't hear anything and haven't been able to since you started.
You can't hear me either? Can you guys hear me here?
Yeah.
Okay, can you put the entire thing, because the only thing I saw is switching on. Can you distance sites hear me now?
Yeah.
Alright, hold on.
Anything can happen. So I can't see them now. Distance sites. Can you guys hear me? Can you? Okay. How about Shreveport? You can. Topeka. Oh, hold on, Topeka. I didn't see it. Topeka, can you hear me? Yes, you can. Okay, so let's. Where did I start? So there are three spinal lineages that we know about in our nursing years. The first one is the dura mater. It is the outer layer, is the strongest amongst the three meninges. It starts at the foramen magnum and it ends at the S2, so that's where the end of your dural sac. It's actually in S2, that's where it fuses with the phylum terminale. The word terminale is the end, right? For us, especially when we're talking about spinal anesthesia, we're more focused on the space between the arachnoid mater and the pia mater, which is called the subarachnoid space. And as I was saying earlier in the group, the subarachnoid space is the target to put the local anesthetic when we're doing spinal anesthesia. So I mentioned something about if you go midline and you hit the subarachnoid space to the right, or you hit the subarachnoid space to the left, or midline, you know you're there, you're in the right spot, because all of a sudden you're going to see a CSF, a clear liquid that's warm to touch, because it's inside the patient's body, right? So it's warm to touch. Now, every now and then, sometimes when you hear the pop, so when you cross the ligamentum flavum and you finish crossing that, you're going to hear the pop, boom, kind of like that. You're going to feel it. Some of us can hear it. Sometimes when you stop, you're still in between the space, between the arachnoid space, and every now and then, rarely, but every now and then, you're going to see that even though you hear a pop, you don't see a CSF coming out. So what you need to do is, we're gonna look at the troubleshooting technique. You can just rotate your needle, and then you're gonna see that CSF coming out, and that's the time you can inject your local anesthetic. Okay. Each of you are gonna be doing your own spinal anesthesia and epidural anesthesia, and we give you your own kit. So you don't have to worry about borrowing from somebody's kit. You have your own kit. The good thing about it is we have so many needles as well. Because we learned from our experience in the past, a lot of our students are artists. They're not only scientists. You guys think A&P, pharmacology and stuff, but you tend to make the straight needle very artistic. You're like a Picasso. Some of them look like this, Some of them goes everywhere for some reason, I don't know how. But it's good, so we give you extra needles when you're doing your spinal and epidural. And you're gonna see it. Some of you will hit your spinal area very quick. Some of you will hit the bone, and by the time they pull the needle, for some reason the needle is letter L now instead of a straight needle. You're like, how did you do that? You know, so we have fun in the lab. So as long as we don't sting each other. Okay, so now we go to CSF. So CSF is produced at 20 to 25 20 to 20 to 25 ml. I have a backup. Okay, 20 to 25 ml. Don't worry about the number as long as you know that there is such thing as CSF. What I really want you to know is it can't be cloudy. Okay? It can't be cloudy and it can't be red because if it's red, it's probably not CSF. It's probably BLOOD, right? And if it's BLOOD, then we're not in the right space, right? We're on the lateral portion of the spine. Remember, the veins are located laterally in the spine. So if you're in that area, you're not in the right space, don't insert or don't inject your local anesthetic, especially if it's bupivacaine, because you know what bupivacaine does when you give it IV, right? Yeah. All of us know how to do codes, but it's really hard to do codes in the OR. So we don't want to do that. Remember the term dermatome, right? Dermatome. The dermatome, you've seen this before. These are the landmarks. And so now let's start doing our spinal anesthesia. Okay. Tooth-pierce line. How many of you have heard about that? It's a European term, tooth-pierce line. We don't really call it tooth-pierce line. We just call it the line that crosses the superior iliac crest, and then it crosses the body of L4, or it crosses the interspace between L4 and L5. So how do we do that? I don't know if you see the picture here. This is a picture of a hip. I was going to say Shakira. But how do you determine? So I'm fat, so if somebody's skinnier than me, it's easy to feel where the hip of the patient is, right? So put your 4 fingers over here and then use this hand like this as what he's doing. And then you target, so this is where you're crossing the superior iliac crest. So your superior iliac crest is the superior of your hip. Right? So it's easy for many of our patients who are skinny. What if they have a BMI of 50? Right? Sometimes you don't know where it is. Sometimes you look at their back and all of a sudden you're like, okay, where am I? Where am I at? Right? So the next thing you can ask the patient is, ma'am, sir, can you tell me where your hips are? So they, well, how do you say it in a nice way? So I always like, can you tell me where your hips are? And then they tell me it's here, so I start touching it, and then I just put parallel to that area. That would be my L4. So that's how to start your spinal anesthesia, to do the superior iliac crest, L4. So this is where your target is. Now, some of you, so when I used to work full time, my right thumb has always the longest fingernails. And every now and then I sharpen it. Sharpen in a sense, so that I can mark the patient's back with my thumb. It's not gonna hurt the patient, I promise you. I've never hurt any patient before. But I usually use this thumb of mine with the longer, and I mark where the two-pier line is, where the 2 lines meet. Now, some of you are very artistic. You want to use that surgical pen. Want to do that? That's fine. I have a CRNA who will do this. He'll do and then if you look at the patient, Brian, as his name, what are you doing? Oh, that's how I was taught. So he would write the horizontal, and then the vertical is, your vertical should be aligned with the, what do you call this one over here? Center of your head, and it should align with the crack of the patient. What do you call that then? Is it a crack? Right? So you have to make sure it's aligned. That's the reason why they have to be sitting straight for you so that you can determine that's the straight line. You can't, no, if there's scoliotic, we're going to talk about that because that's another story, right? But you make sure that the vertical line and then you use a horizontal line. Wherever the two meets, that's where your injection site is. That's your target, okay? So that's the two-pier line. Now we're going to talk about the drugs. Okay. So somebody asked me about cauda equina earlier. As a matter of fact, when we put our local anesthetic, it's going to coat all the cauda equina area, right? When they're sitting on the side of the bed, if you're doing it on the side of the bed or in their lateral position, for some way or the other, some of those local anesthetics are going to go to the cauda equina area. Okay? So the local anesthetic, we're actually injecting it in that area so that it's going to coat the spinal nerves of the cauda equina. Okay? So spinal nerves, the smaller they are, we talked about it, the more susceptible to blockade. The more myelinated they are, the more susceptible they are for blockade for your local anesthetics. Now, Dr. Kane has talked to you guys about various types of local anesthetics. We're not going to cover all of them here. I'm giving you an example on some of the local anesthetics that are commonly used. Now, I'm going to pre-warn you that some of the hospital may not use this same technique. What they're going to do is they have specific local anesthetic, the type, whether it's hyperbaric or isobaric or hypobaric. Who's going to Plaza? Plaza likes to do isobaric solutions because they just want to stick it there, right? So a lot of the hospitals will do hyperbaric solution. Every now and then I play with hyperbaric if I have a student in the room. But most of the time I'm a hyperbaric guy and I'm an isobaric guy. Now, if you look at this, please don't remember the dose or the time. What I want you to know is these are specific drug doses. Now, this is based on some studies. So this is not hospital to hospital, right? Because hospital in Fort Worth may do it differently than hospital in Little Rock, Arkansas, or Bismarck. But it just tells you that there are a specific number in terms of dosage. The more you go higher, so if you want to just block T10, as you notice, the amount of local anesthetic is lower than if you want to block T4. Remember, T4 are upper abdominal procedures, right? Remember in our previous class. So if you want to block T4, you want to go a little higher in terms of the dose. Okay? So that's just giving you a picture. Now, remember Dr. Kane talked to you guys about epinephrine as a vasoconstrictor, right? Right? So that alone would actually extend your local anesthetics. Now, do we always do that? We rarely do that. The only time you do it if you probably have a new surgeon in the OR and he is probably a second or third year that you just want to give yourself a little time. Majority of the time when we do regional anesthesia, we take into consideration the surgeon themselves, as well as the type of procedures. So every now and then, if I have a new guy in the room, politely ask them, hey, I usually give, so let me just give an example in Plaza. When we do HIP, I always give 3 cc of isobaric bupivacaine, 15 milligrams, 3 cc. So every now and then I'll ask them, hey, is it gonna be 4 hours? So, and then if they tell me it's 6 hours, every now and then I'll make faces. I'm like, oh man, I'm just gonna go to sleep, right? But then every now and then they know that I joke with them. They say, hey, Tito, around 3. So 15 milligrams of a isobaric solution for a hip or a knee is pretty damn good to last that 3-hour long procedures. Okay, so you will learn that each hospital and each surgeon have different types of likes that they like in terms of the drug. How long? Do you want to add epi on it? Do you want to add fentanyl on it? Do you want to add morphine on it? So you're going to figure that out as you train in the OR. Now, speaking of morphine and the vasoconstrictors, we have what we call, when we put it into drugs, we have what we call additives. So additional drugs that you put in your local anesthetics. So I just term it additives. Okay? So if you want to prolong the block, you want to add your epinephrine or any vasoconstrictor. And then if you want to intensify the block, meaning to say you want to solidify your sensory blockade, it's really going to feel good. As a matter of fact, this is really good if you're going to do epidural. We're going to talk about epidural anesthesia. But if you want to do that with your spinal anesthesia as well, you can do opioids. That means you solidify and you make your sensory block very good. Good and profound. I'll just use the word profound because that's what researchers would always do. Okay? So when you add opioids, it's still the same. So fentanyl, morphine, sufentanil are mu receptors, right? So it makes sense that it should bind the mu receptors, right? Remember mu receptors, right? It also blocks the sensory inputs of A and C fibers. We're going to look at these fibers again. So A and C fibers, and they either come with hydrophilic solution or lipophilic solution. And the reason why you need to know whether they're hydrophilic or lipophilic is because of the complications associated with that opioid. Okay? So the first one, let's go with, it's morphine. So morphine is a hydrophilic solution. So it's hydrophilic. It spreads into the intrathecal space gradually. It's very slow because there is decreased volume of distribution. The problem with morphine is this. So what's the clinical implications of delayed respiratory depression? So as trainees, as RRNAs, this is what you can tell. You report this to the post-operative nurse, PAC nurse, and tell them, we gave morphine. And if they didn't get the clue why you tell them that, you say, we expect delayed respiratory depression. So guess what? Where do you think the respiratory depression occurs? In the recovery room or in the floor? In the floor. That's the reason why they tend to keep the patient a little longer in the pre- and post-operative department before they bring the patient in the floor. And when they bring the patient in the floor, they're being monitored with a pulse oximeter, right? So that's the clinical implication of delayed respiratory depression. So these are a couple of the dose. This is what I do in the clinical practice, 0.1 to 0.5 milligrams. The problem with morphine, like any other opioid, actually this is the number one complaint. Itchiness is the number one complaint of our patients who get a spinal anesthesia and we put morphine or opioids in it. They don't remember that they didn't feel any of the pain during surgery. They remember that they're itching. Like you will see, and Dr. Kunz can tell you this, there will be some patients that they will scratch their skin as if the epidermis sometimes comes off. That it's an itchiness that's hard to control. It's really hard. There are some drugs that can be given. Nupain is one of them. But it's still going to happen. Despite interventions, preventive interventions, you're going to have all of this. But the most common is pruritus. So this is So that's your hydrophilic drug. Let's go to lipophilic agent, which is your fentanyl and sulfentanyl. Many of you like that. I like that too. It's very quick, rapid response. Your respiratory depression is a little bit earlier. Sometimes it happens in the recovery. Sometimes it happens in the recovery. So which is a little bit easier for us to manage because we're there, right? We're there in the OR and they're in recovery room, so they can just call us and we can troubleshoot this situation. It's still gonna have some issues with nausea and vomiting, okay? Pruritus, you're still gonna have that issue. Again, the common complications associated with fentanyl and sulfentanyl is also pruritus. Out of those three listed, it's still pruritus. Okay, small doses intensifies the blood. With these two drugs, specifically fentanyl, it reduces your local anesthetic dose. Now, what is the clinical significance again for that? We will go through some of the complications of the local anesthetics that we give in the spinal in a couple of slides. But one of those complications, and we talked about it, I talked about it during assessment, was the blood pressure and the heart rate. Lowering the dose of your local anesthetic can actually minimize hypertension and bradycardia. The problem is, spinal anesthesia is only one shot, right? You give the local anesthetic, you start the procedure. There's no catheter that you can give additional drugs, unlike epidural anesthesia. So in spinal anesthesia, you have one shot. So let's say that hip replacement that I talked about, and I said I give 15 milligrams of isobaric bupivacaine. What if the surgery lasted for 5 hours? I may not have enough of my local anesthetics in there, right? So what's the next choice? The next choice is, if the surgery is not over yet, you probably have to intubate and do general anesthesia on this patient. So you end up with 2 anesthetics for that particular day. So lowering the dose of the local anesthetic is good as long as you have a way of topping up that local anesthetic. And the only way you can do that is if you have what we call a combined spinal epidural analgesia, wherein you give the local anesthetic via spinal, but you have the catheter. Remember the catheter that comes out of the patient's back? If the patient starts, oh, I can feel that, I can feel that, I can feel that, you can give additional drugs using a local anesthetic using the catheter. So lowering the dose of local anesthetic, hey, it's good. I'm not as brave yet. Every now and then, if I have a case, I say 15, oh, I'm gonna need 15. I'm not gonna play with, oh, I'm just gonna give 12 or I'm gonna give 10. Every now and then, that 15 milligrams, if you have a bad day or it's one of those days where you're shaking too much, that becomes 12 milligrams, right? Because you're like, it's sort of coming off, like, where is the drug going, right? But if it's 15, I stick with 15. The only time I lower my anesthetic dose, local anesthetic dose, is if I have an epidural. If I have the catheter over here, I can give additional dose in the OR. Okay? Sulfentanyl, 2 to 7 micrograms. This is for labor. A lot of the CRNAs use, I'm not sure if Dr. Kunz used sulfentanyl on his practice. I do a lot of sulfentanyl. Every now and then the recovery nurses or the OB nurses, not the recovery, they're like, you know, the outburst score of the patient, you know, the baby's like 7 or 6. Okay, next time. Because remember, drugs travel to the placenta, crosses the placenta, right? So every now and then, it's like, hey, your babies are drunk. Okay, sorry. 2.5, but the patient felt good. And the whole time she's texting, she's pushing. Gene, push, Gene. Facebook, selfie. That time we don't know what it's called, but it's called selfie now. 2.5 to 5 micrograms. So remember, there are micrograms. very small for C-section. Okay, see common complications are these three, but this for opioids, this is the most common. So I'm just gonna, okay. And then we can add vasoconstrictors, vasopressors, to lengthen the anesthesia, the analgesia, right? So these are some of the concentrations that are being used, but commonly we use what we call an epi wash. Have you seen an epi wash? Okay, so an epi wash, we're going to show it to you during your. So an epi wash is you have a syringe where you put your local anesthetics, and you have the epinephrine or nicotinephrine, whichever drug you use. I like this one if I need to do a vasoconstrictor. So I'll put the epinephrine in the container for the spinal. Let me show you where it is. This is actually your spinal. We're actually going to teach you how to open this symposium. So pardon me if I'm opening it. I'm not opening it right. So you usually go like this. Why is it blurry? Huh? So I'm not happy here. Oh yeah. So do I go closer? Okay, it's epic, just trust me. And so what I do, I open this and I put it in one of the, I don't have the bigger one. You can put it over here, so you open this up, and what you need to do. Can I have water? Can I have your water? A little bit. I'm not gonna drink it, I promise. Can I just, I'll just put the, okay. Sorry, I'm so not prepared. I am prepared, but it's not. Okay, so. Thank you, sir. So an epi wash is, so this is my epi. What I'm gonna do, I'm gonna open it and I'm gonna put the drugs there, right? So assuming that water that I borrowed from Jeremy, that I got from Jeremy is your epi. When we say epi wash, so this is your syringe, by the way, for your spinal anesthesia. And I don't know if you noticed, well, you can't feel it, but you can't go higher than 5. Because you don't want to give too much, right? Whereas the epidural, which I don't have, you 20 cc. So, but if that's your epi, so when we say epi wash, what you do is, since this is going to be your local this is going to be the syringe for your local anesthetic, what you do is you get that epi and you wash the syringe. That's what we call epi wash. So you just coat the inside of the syringe and then you squirt it up. And so you have some epi on the inside of the syringe. We call it epi wash. That's how we do when we do epi wash for vasoconstrictors. Okay? Okay. We're going to look at that later. Thank you. Okay. So that's epi wash. Tetracaine, I don't know if you still use tetracaine. If you want your patient to be numb for a long period of time, tetracaine is it, right? You don't want to do that. A lot of our patients may complain that they don't feel. It's really hard for them not to feel their legs. It's really hard. So with tetracaine, it's going to be profound, and then you put a vasoconstrictor. Oh my God, it's going to be more profound. Their numbness is going to be there for a long period of time. They're not going to be able to go home that day. So they're going to blame you for that. So As much as possible, try not to use the tetracaine if you can use it in bupivacaine because the variability in terms of their prolongation is very variable, so it's better to use that in bupivacaine. Okay? And then there are other additives. So remember the two additives so far we talked about would be the vasoconstrictors and the opioids. There is also another additives. You probably heard about Presidex. You also probably heard about clonidine. There are alpha-2 agonists. You can also use that for your additives for your local anesthesia. Okay. Now, in terms of absorption and uptake and elimination of the drugs for spinal anesthesia, so we know that the local anesthetic is injected in the subarachnoid space. It's going to coat the nerve endings or the nerve roots of the cauda equina, and it's going to spread all over that area, which is what we want, right? Now, if your goal is T4, it has to go to as high as T4 sensory. So how do you do that? Depending on the veracity of your local anesthetics, and we're going to go there in a few slides. So in terms of uptake, all the uptake are higher if the concentration is high, if there is a lot of surface area for the local anesthetic to go, if it's more lipid soluble, and if there is high blood flow in that area. So the uptake is high. So therefore what it means, it's going to be consumed faster, but it's going to work faster. So when we say uptake, I know you guys learn so many things about uptake. When we talk about uptake for local anesthetic and a spinal technique is it's going to work very fast. So meaning to say the onset is faster. It's faster, so good, the numbness stays or the sensory block stays. But then if there is a lot of blood flow in there, guess what? The local anesthetic will be absorbed faster as well, right? So you have to balance that as well. Yes, ma'am?
On the alpha-2 agonists with the clonidine and the dexmedetomidine, are those weight-based, or is it just like 15 mics that we're adding?
15, they're not weight-based. Thank you very much. 15 mics, remember it's mics. So they're very, very minute, very small, very small. The clonidine has been used for a couple of years. Dexmedetomidine just came into play lately. There are a lot of orthopedic guys that like to do clonidine, but it's not weight-based. This is it. This is the drug. This is the dose. This is the dose. Okay, so the concentrate. So if the concentration of the local anesthetic, like earlier I said, which one will work faster? 0.0625% or 3%? The answer is 3%, right? It's gonna work faster. The onset is gonna be faster because the concentration is high. Surface area. If we inject it in the cauda equina area, you're gonna have a lot of surface area in there. You're gonna cover the coverage or the block is faster than if you put it in somewhere else. Well, if you do spinal anesthesia, you only put it in that area anyway. You can't put the spinal anesthesia in the thoracic area. The local anesthetic can go to the thoracic area, and we're going to talk about how would it go there. How would it go there? Blood flow. The more the area has blood flow in it, so increase circulation, the drug is going to be absorbed faster, so you're not going to have a lot of time for that drug, right? So you want to make sure that you have enough dose to cover for that particular surgery. Okay? Okay, now, there is such thing as differential block. So what I'm saying, when you talk about differential block, you talk about areas that a local anesthetic is going to produce some of its sensory blockade. We talked about earlier, the smaller the diameter, the more profound the blockade is. If they are myelinated, the more profound the blockade is. But there are certain concepts which we call differential block, because when we talk about spinal anesthesia, we talk about 3 areas. Okay? We talk about, let me just jump here. We talked about sensory, that's the main thing. But there are 3 areas as well. You have sympathetic blockade and you have motor blockade. Okay? Before we're gonna go there, let's not go there for yet. But this is what I'm just gonna show you. This is kind of my configuration of a nerve bundle. So this is a nerve bundle. This is one nerve bundle, brown. And inside the nerve bundles are all these fibers. And as you could see, I listed them, B fibers. The green one are alpha, A alpha, A beta, and A gamma, right? And then the blue is A delta fibers, so you can tell these are sensory, these are pain, right? Remember Dr. Schmidt, and C fibers. So C fibers is purple over here. So this is the bundle, and you put the local anesthetics here. You put the local anesthetics here, right? So common sense or something will tell you that if you put the local anesthetic here, the first thing it's going to touch is this one, right? Right? Because it's the outside. If you look at a nerve bundle, okay? So I'm going to show you over here. Hold on. Okay. So this is the progression. So when you put the local anesthetics on the cauda equina, and it's going to target just one of the cauda equina. So what's singular for cauda equina? A horse. So if you put your local anesthetic on the side, the first thing it's going to go is this one, B fiber. The first thing it's going to do is it's going to block the V fiber. What's the V fiber? It's the autonomic system. So what do you think the first thing you're going to see when you put your local anesthetic? Bradycardia. Those autonomic nervous system. Hypotension. That's the first thing you're going to see, right? And then the second thing, I'm going to go back over there, is this purple. These are your C fibers, followed by these blue, which are your A delta fibers. Guess what? They are pain and temperature. So once the local anesthetic goes there, it's going to block B fibers, and then the next one would be the C fibers and the A delta. And then, as you can tell, number 3, it's going to be A gamma, so you're going to lose motor tone. And then followed by A beta, which is touch and proprioception, actually touch and pressure, I'm sorry. And then the last one is loss of motor function. So this is motor blockade, complete motor blockade and proprioception. Now, I don't know if you've been to the OR. How many of you had experienced somebody who had a spinal anesthesia and then the nurse would say, but the patient is moving. Like the patient is wiggling his toes, or so he's not ready yet. Because if you look at it, the patient is not feeling pain because pain and temperature are already blocked because it's C fibers and A delta. But this is the last one that is going to be blocked. It's going to take a while. Now, is it going to be blocked? It will be blocked. It's just going to take a while. So what you need to tell the nurses like that, because they always tell you like, can we put the Foley catheter already? And the answer is once you start testing for temperature, for pain, once you're sure that it's already where you want it to be, and you can tell the nurse, yes, you can put the Foley catheter. They're concerned that when you put the Foley catheter, the patient is going to feel the catheter, right? So they're going to say, hey, I can't put the catheter yet because the patient's still moving. I always tell them, it's okay. I already test for the sensory blockade because this is your sensory. These two are your sensory blockade. You can put your Foley catheter. She is not, or he is not going to feel it. And then, but they say, but the patient is wiggling. So then I start talking about, we'll talk about differential blockade later today. I just let them, let's talk about it in recovery or during lunch break. So I can tell you that the last thing that would ever happen would be motor blockade. Okay? Now, this is just an example of the nerve fibers that I just talked about. But this is something that I want you guys to remember. So sensory is in the middle. The sympathetic level is 2 to 6 levels higher than your sensory level. 2 to 6. So let's say you're doing a C-section, T4. So C-section is T4. So you're doing T4, you already reached T4 because you checked. Remember T10 is umbilicus, right? T4 is, where's T4? Yeah, right? Okay. So you check, you know the patient doesn't feel any cold sensation because remember, pain and temperature, remember they travel together, right? So one way to determine if the patient is not hurting anymore, is not going to feel any pain, is to do temperature test. Do not get a needle. Oh, I have some CRNAs that do that. They'll get the needle of the stylet of the what do you call this one? Spinal anesthesia. They get the stylet and they use this to poke the patient. I don't like that because I don't know if it hurts. Otherwise, I'm going to try it. So this is the stylet. They do this to poke the patient to determine if the pain sensation is gone. What I do, because remember, pain and temperature travels together. What do? I use the cold temperature of the alcohol swab. I have in my OR, when I used to work in a small town, I have a small teaspoon in my OR. Because if you put the teaspoon in the OR for a long period of time, it's pretty cold. So I use that to determine temperature. So let's say you go T4. Did it say T4? Yep. No, it says T5. So let's say we're going to go C-section. Let's go C-section T4. So that's your sensory block. What's your sympathetic blockade? If it's 2 higher, so T4, what? 3, and so T2, T1, T2, T1, C8, C7, C6, C5, 6, right? So they're not gonna feel it. So what is T1 to T4? Cardio accelerator nerves. So guess what? Your heart rate is going to be going down at this time. And guess what? In real situation, when you have a C-section, you're going to have hypotension and you're going to have bradycardia big time. Just anticipate that. So you got to have to prepare the drugs needed when you have a C-section that you're going to target T4. Now, what does it say again here? The sensory level is 2 levels higher than the motor level. So if the sensory level is T4, what's the motor? 5 and 6. 6. Who said 6? 6. Right? So T6. So are you getting this? Okay? So if you're so let's say we're doing a TURP. What's the sensory level for TURP? T10. T10, umbilical area. So if I have T10, what's your autonomic blockade at T10? So T10, 8, right? 7, 6, 5, 4, 3, right? So guess what? Most of the time, so 3, most of the time, when you have T10 level, you're going to have bradycardia and hypertension as well. Why? Why? Cardio accelerator nerve, T1 to T4. You have 4 and 3 in there. You're going to have that bradycardia. What's the motor level at this? What's the motor blockade if you're doing TURP at T10? 12, right? 12 and then L1, anything that's down, right? Right? So they're not going to be able to move, right? So that's differential blockade. That's how to answer nurses who are, hey, can I put the Foley catheter now because the patient is wiggling. And you tell, hey, you can go as long as you get that level that you desire for that particular surgery. Now, what happens in the recovery? So this is what happens in the OR. After you put the spinal anesthesia, this is what's happening. It blocks the sympathetic, it blocks the pain, the motor tone, touch and pressure, and the motor function. So the patient is already numb in here, not moving anything. What happens in the recovery room? What do you think happens in the recovery room? Because remember, once you put the local anesthetic in the spinal area, subarachnoid space, they are already being absorbed in the system, right? So guess what? Your blockade starts to recede, starts to go down. So let's say you have T4. By the time you go to the recovery room, it's going to be T5, it's going to go down to T6, it's going to go down to T7 until it wears off. So the first thing, so it occurs in reverse fashion. So remember reverse. So the last, remember during induction, this is the last thing that happens. So let's go there. Remember, there you go. See, this is the last thing that happens. But in the recovery room, this is the first thing that happens. They start moving again. But then they're still comfortable. I don't know if you noticed that. They're still comfortable. They can't still pee, right? They're like, because we can't discharge them if they don't pee, right? So the nurses waits, like, can you pee? They have to feel the sensation that their bladder is full before they can pee. Now, every now and then, I've ordered a couple of times already, I would order a Foley catheter because it's like 3 hours and still not able to pee. And you know that the patient has a lot of fluid in there because we're going to talk about what we're going to do when we have problems with hypertension in the OR, because it does happen. It does happen. Whether you like it or not, it's kind of like the sun rises in the east and the sun sets in the west. It's going to happen. So we have to prepare for these issues. And we're going to talk about that after break. 10 minutes. Elimination of the local anesthetics in our spinal anesthesia from the CSF are usually from the epidural blood vessels that are in here. So if the drug doesn't have a vasoconstrictor, and if the area that is where the local anesthetics are located are highly vascularized, which is probably all parts are vascularized, then the elimination is going to be faster. Okay? So, factors affecting intrathecal spread, and this is the things that you need to know. You need to know the factors in order for you to decide what kind of local anesthetic I'm going to use, how much dose am I going to use. Am I going to use opioid with that local anesthetic, or am I going to use some sort of a vasoconstrictor for that local anesthetic? So the first one is take into consideration the dose and the length of the surgery. That's the reason why communication is very, very important, especially to talk to the surgeon. You need to be able to communicate with your surgeon. Now, I understand the first week may not be as comfortable as probably like a month later, but try to be able to communicate with your surgeon. Learn how to be respectful. Sometimes I can tell you the OR environment is a little different. Sometimes it can be nice. Sometimes you don't expect. All of a sudden, you hear some words where like it's not supposed to be said in the OR, but kind of like Vegas. Whatever happens in Vegas stays in Vegas, kind of thing. Every now and then, students tend to talk to the surgeon, which is for me, I'm okay. But there are some CRNAs or anesthesiologists. They want you to be quiet at first. I don't understand that. I like my students to talk to the surgeons. Of course, communicate with them what's going on in the head of the bed, right? So you will be able to learn how to communicate with the surgeon. And then I put another factor here, and I know if you know a surgeon, it's not that I don't like them. Sometimes there are just some surgeons who are a little bit slow. And CRNAs always, or anesthesia providers always equate that somebody is good if they're faster. I know a lot of surgeons that are slow and their products are really good. So it's knowing how fast they are or how slow they are sometimes affects your anesthetic. Now I can tell you, if you have a surgeon that's really, really very slow, like would require a microscope to suture, then probably spinal anesthesia is not an approach. Because remember, spinal anesthesia is only one attempt. You can't troubleshoot it, okay? So that's one of the factors that you need to determine before you decide whether I'm going to do a spinal anesthesia, what kind of drug and how much am I going to give, or do I have to add opioids, or do I have to add vasoconstrictor. The next thing is age. So I'm just going to summarize this. The older the patient, the faster the onset of the local anesthetics. There is high level of blockade, and anesthesia tends to be longer when you put your local anesthetic in here. And a couple of reasons, as you could see here, neural nerves are vulnerable to local anesthetics. The number of myelinated are decreased. The velocity of the motor nerves are also decreased, but guess what? This is really most important thing in aging. The CSF fluid or volume is decreased. So it's kind of like, so really what you need to remember here, it works faster, it stays longer, and you probably need a lower dose. So think of a black coffee. So you have two coffee in your hand, one 16 ounce and the other one is 32 ounces. If you put 1 drop of creamery on the 16 ounce, it's gonna coat it a little faster than if you put a drop of milk in that 32 ounces because the CSF is small in terms of volume, okay? So a lot of us would try to use spinal anesthesia on older patients because of the hemodynamic instability that is brought about by our inhaled gases. The propofol that we give, although we have other IV induction drugs, but most likely we give propofol on our patients. So it's advisable, it's really good to have a patient, elderly patient, to go regional technique. In terms of their mentation post-operatively, they are less confused waking up from a regional anesthesia than waking up from a general anesthesia. You've seen that in ICU. We've seen that in ICU, and you're going to see that in the OR as well. They're a little bit confused sometimes when they wake up after general anesthesia. The gas makes them a little bit different when they wake up. Now, in terms of height, normal height patients is not really a big issue, but taller patients, there is an issue in terms of the spread of the local anesthetic and then the weight, okay? So restrictive lung disease, because obesity, if you look at obesity, if you look at the pressure volume loop, pulmonary pressure volume loop, obese patients tend to have a restrictive lung disease. Patients who are morbidly obese because of the weight decreases the amount of CSF. And if it decreases the amount of CSF, therefore, the onset is faster, right? So similar to here, the onset is faster, the level of blockade is higher, there is long-lasting anesthesia, so in other words, the spread is higher than a non-obese patient. So you would notice that when you have a morbidly obese patient, your dose is a little bit lower. So an example I said earlier with isobaric, when I do hip replacement, do I do 15 on morbidly obese patient? I don't really. So I do 12 or 12.5 milligrams on my isobaric solution because I know morbidly obese patient has decreased CSF and I don't need a lot to cover the space that I need to cover. Okay. In terms of the number of CSF, this is a good table. It tells you that The smaller the CSF volume is, the spread is a little bit higher. Or the peak, they call it the peak in research studies, that the peak of the local anesthetic blockade is higher. And this is a very good table that tells you the lower the amount, so these are the volume, these are the blockade. The higher the blockade or the spread of the local anesthetic. So the more you have more local anesthetic, it tends to be on the low side, which makes sense. As I said, the example I told you about the coffee, black coffee, 16 ounce and 32 ounce. The spread is a little higher. So where's the injection site? Remember we had the two Pierce line running in what level again? What level? L4, right? The body of L4 or the interspace of L4 and L5. So where is the good injection site? As you can see here, L2 and L3 spread is higher than L4 and L5. Looks good, right? Well, remember we have L1 as the end of our spinal cord, right? Now, I'm gonna suggest for you guys, you can do this probably next year, right? Because you've been doing it for a while. But this August, if you're doing a spinal this August, please start at L4, L5, just to be safe. Just to be safe. Okay, so you do your two Pierce line, that's L4, right? And that's L4, L5 interspace. Inject your local anesthetic in. That's where you put your local, that's where you put your needle there, instead of going higher. You can go higher because remember, L1 is the end of the cord. I tend to do this because this area tends to be wider. The spaces between L2 and L3 is a little wider than the spaces between L3 and L4, because the spaces in L3, L4, I hate to say the word stenotic, but it tends to be a little bit tight. The tendency is you're going to be hitting a lot of bones during that time, but we'll talk about how to navigate if you hit the needle and you hit the bone when you insert the needle. To be safe for your practice for the first semester, use L4, L5, and then by next year, if you've done 50 spinal, oh my God, go L2, L3, yeah, you know where to go. You know where to go. But to be safe, I'm going to tell you, your clinical coordinators and the CRNA that's going to be working for you on the first day, the first semester of your training, they know that their goal is to make sure that you can induce the patient from the beginning, do the maintenance, and do the emergence. So it's not only for general anesthesia, for regional anesthesia, you do a spinal induction, management intra-op, and post-op. So they're going to make sure that you're going to be able to do that. We're not going to, I would say 95% of you guys are going to get your intubation quickly on that first month. There will be 5% of you guys that are going to be struggling. You're like, where is the cord? Where is the cord? Don't feel bad because we know at that stage, we will try to help you determine where the cord is. We don't expect you to be so good. Oh, we have a lung case and we're going to put Randy in there. We don't expect Randy to be able to put the double lumen tube in that patient yet. Now, they're going to help you. They're going to make sure that you're going to tube the right area, but they're not going to leave you alone. So please don't be worried about training. Enjoy the training as much as possible. Enjoy the training. It's a lot of work, but enjoy the training. Okay, so there are techniques. So this is the injection site. You can go here, but I advise you guys to go here on your first semester. Second semester, spring next year, just remember this, right? Wink, wink, wink. Just remember that. We have insurance for you, but still. It's really good insurance for you guys. Barbotage. Have you heard of barbotage? This is another technique in spinal anesthesia wherein you inject a local anesthetic. So you already know where the area, so you're, let's say L4, L5, right? You inject the local anesthetic, you saw the CSF coming, you remove the stylet of that needle, And then when you put the local anesthetic in there, instead of pushing or injecting the local anesthetic immediately to the subarachnoid space, you aspirate a little portion of that local anesthetic, and it's gonna form a wheel, kind of like, like the milk in the black coffee thing. It looks like a wheel because you're gonna see it. It's gonna have a little wheel in your syringe. That means you're aspirating a few amount of your CSF. So you're actually mixing the CHF to your local anesthetic. You're actually mixing it. So you inject, you aspirate, and then you push. Let's say you have 3 cc. Let's say you have 3 cc in your syringe. You're going to give 15 milligrams of isobaric. So what you're going to do is you aspirate, give 5 milligrams, because you have 15 milligrams, right? Aspirate again, give another 5, so you gave 10 already. Aspirate again and give the remaining, and pull the needle together. You pull the needle together because you don't want to pull it one at a time because of shearing. You don't want to pull the needle and all of a sudden it cuts part of the introduce or the needle inside the patient. So you want to put the needle together. Okay, I'll show you this. I'll show you a demonstration. So barbotage. Now, a lot of studies shows that it doesn't work. Anecdotally, it does work for me. It's like quick onset. It's like you're mixing the local anesthetic in the syringe with the CSF, and by the time you push it all, it's already swirling in the patient's back. Like, yeah, we're mixed already. Yeah, they're gonna work. We can start surgery right now. So it's called barbotage. I just like to pronounce the name. Another name for the dog, Amanda. The dose of the local anesthetic. In many studies, larger doses increases the spread of the local anesthetic. Makes sense, right? Larger doses increases the level of anesthesia and the block duration. It makes sense. So the larger the dose, the better it is, right? Because not only you have more local anesthetic in your syringe, you can coat a lot of spinal nerves inside. Okay? Okay? Okay, so you've heard of veracity with Dr. Kane. You know there is such thing as isobaric, so I'm just gonna put stays where you put it. But when I say stay where you put it, it also means that when you put it in L, let's say L4, when you put the patient on his back, remember that local anesthetic is still gonna mix with CSF, right? But so therefore some of it will be spreading either higher or lower, but it's not gonna go float or it's not gonna go sink. It's just gonna stay in the middle of your CSF, right? So that's a good local anesthetic. Hyperbaric is lighter, it floats, and then hyperbaric is the one that's heavier and it sinks. So this is mixed with normal saline. This is mixed with sterile water and D5. Okay? And then there's a good picture here. Isobaric put it, hyperbaric sinks, and then hyperbaric floats. What do you think is a perfect hyperbaric? And what do you think is a good surgery for hyperbaric? Have you guys seen a hemorrhoidectomy? Like hemorrhoidectomy. You know how we put the surgery, right? We put them like this with their. Have you seen Endgame? Remember Ant-Man said, "Flick me." I like that. You like that. So that would be a good surgical procedure because you want the local anesthetic to float, right? Because ching, right? It should go ching, go higher, right? So this would be a good hemorrhoidectomy procedure. But most of the time when we do hemorrhoidectomy, we do general because of the position. It's kind of prone with the tank top. So this is how it looks like. Oh, some sauces, it floats all over, like this. And then it sinks, but it still goes to the lowest portion, right? What's the lowest portion here? Remember that here. Okay. Pulmonary changes, physiologic changes. We're gonna go here, we're gonna go here, we're gonna go here. They always shake. For some reason, they always shake. So let's start with cardiovascular. So there is always a loss of sympathetic tone. Because of the loss of sympathetic tone brought about by the local anesthetic, you're gonna have severe vasodilation and, forgot to add here, venodilation. Because there are so much blood in the vein, venodilation. So since there are so much blood in the vein than in the artery, the venodilation supersedes vasodilation. It's still a bad thing. It's still hypotension. Decrease SVR, as you can see, decrease preload, decrease everything. CVP, that means decrease CVP. You end up with decreased cardiac output. Guess what happened? You have that. And because of blockade over here, since this is the cardio accelerator nerve, you're going to end up with a bad case of bradycardia. When you combine bradycardia and hypertension, it's not good. Why it's not good? Remember, cardiac output is equals to heart rate and stroke volume. If you already have problems with some parts of your stroke volume, i.e. your preload, and you already have problems with your heart rate, i.e. bradycardia, you put them together, it's perfect storm. Perfect storm. Okay? So, just want to mention in terms of bradycardia, this really becomes even bad if the patient takes beta blockers pre-operatively. Some textbooks will consider a heart rate of less than 60. Some of us are okay with 50. But anything below 50, it's the sound of that pulse oximeter that is less than 50 is one of the things that I cannot fix this. That's the reason why when you do spinal anesthesia, there are always two things that you need to make sure. When you do spinal anesthesia, i.e. regional technique, you always have to have general anesthesia setup, and you need to have all your vasopressors ready. Like when I say ready, they're already mixed. They're already in the syringe. The syringe should not contain just saline. Okay? The syringe should have ephedrine and the epinephrine, because you will need either one of them when you put spinal anesthesia. Now, it is even very bad if your patient is older and your patient has history of coronary artery disease. So those two syringes should have drugs in it, not just saline. Make sure there are drugs in it. Okay? So management. How do we do patients who's gonna have problems with the cardiovascular system? Well, we try to give them fluids. When I say fluids, you go crystalloids. So crystalloids. And then some of us like to use colloids. Depending on the hospital you go. Oops. Oh my Lord, have mercy. Colloids. Crystal colloids, it doesn't matter. I like my crystalloid because my idea is as soon as they're done, they can pee it out. I don't have any problems with CHF if I have a patient who has who has coronary artery disease. Now, why do you think we don't want any IV that has dextrose in it, that has glucose in it? What does glucose do to the body? Diabetic patients, patients who are DKA and hyperosmolar non-ketonic, they have so much sugar, what do? They pee a lot. Well, if you want to pee a lot, then you're going to be hypovolemic at that time. Well, remember, you have hypertension and bradycardia problem. So you want to use any drugs, any fluid that does not have glucose in it. That's the reason why you don't have glucose. Okay, so management. If the heart rate is okay, and you have hypertension, the best drug of choice, when I say okay, it's not bradycardia. It's normal range. So let's say around 80 to 90 or 100. The best drug is this one, right? Neosynephrine, right? But if you have bradycardia, you need to give the mixed alpha and beta agonist, which is ephedrine. I'll tell you this. In the OR, you're going to have both of these problems, up and down, up and down, up and down. That's the reason why you need to have 2 of your drugs ready. Because if you say the heart rate is 82, but it's hypertensive, you know you can run your knee, right? Okay. Blood pressure is 50 over 20, well, that's too low. 70 over 40, and then your heart rate is 48. You grab your ephedrine. Okay? So everything is ready in there. You don't want to be in that situation where I'm going to mix my needle, I'm going to mix my ephedrine. You're going to look bad. Remember, KIC, everything. Keep it country, keep it simple. Everything should be ready so that when the problem arises, you have everything available in front of you. Remember, 2 years. They can come back in 2 years and say, you did my anesthetic. This is what happened to my kid in Walmart, right? Because you live in a small town, right? So 2 years. So avoid this. Avoid the hypertension as much as possible and treat it as fast as you can. They can go very, very fast, you guys. They can go very, as Dr. Kane was mentioning, it can go very fast. When you have a heart rate of 20, and it's gonna be one of those, and then you're by yourself in the room. Now, as a student, you're not gonna be by yourself in the room, right? When you become a provider on your own, you're gonna be by yourself. What if it's 3 o'clock in the morning? So think about that, okay? Okay, if severe hypertension occurs after, because it can happen, you can give any of your vasodilator. I recommend, favorite of everybody, nitroglycerin if you have available. Remember, nitroglycerin comes in bottles, right? So it's hard to. So if you can't find one, get you a beta blocker, which is a beta blocker. Give your narcotics, your favorite narcotics. Not too much. You don't want to make. You want to make sure that the patient doesn't have respiratory depression as well. And my favorite. I always give that first. Why? I don't want them to remember. Because the baby's already out, right? The baby's already out. There are some hospitals, by the way, you guys. There are hospitals that don't allow you to give Versed. You know that, right? The bonding issue. So you need to make sure in all our hospitals you can. But if you work independently or by yourself already, there are hospitals that don't want you to give Versed to the mother because there is this bonding issue between the mother and the baby. Or the mother doesn't remember she delivered. How can you do that, right? Respiratory problems associated with spinal anesthesia. Okay, so remember phrenic nerve? What was it again? C3 to C5. C3 to C, somebody's not. C5. Okay, so when your spinal anesthetic goes higher, so the tendency is for the mom to feel like something's going on, like I'm having a hard time breathing. But by the time it reaches the phrenic nerve, so C5, so it's really far, far away, right? Far, far, far away. Unless you have a hyperbaric solution, then you put the patient very stiff Trendelenburg and everything went to the head. No, you don't do that. I'm just kidding. But what if it goes that high? It will happen every now and then if you've been doing a lot of spinal anesthesia. You will have 1 or 2. Now, if it does happen, when the phrenic nerve is already blocked, the patient will panic, I'm telling you. the patient will panic, the OBGYN will also panic. So everybody's panicking except you. So you're thinking, you have your face mask, you have your non-rebreather already. Remember, you already prepared the general anesthesia setup just in case you need to intubate the patient. But this patient delivered already, right? So patient already, the baby's already gone, hey, Apgar score of 9 in 1 minute, 10 in 5 minutes, right? 10, 1, and 5. Okay. So 5 minutes, 10. So everybody's okay, like taking picture. Oh, he's so cute. And then you're dealing with the mom because the mom is like, I can't breathe. I can't breathe. What do you need to do? Well, first and foremost, determine what kind of local anesthetics you have. If it's a hyperbaric, that's easy, right? Hyperbaric 6, right? So C3, C5 here. So if it's hyperbaric, why don't you just raise the patient's head a bit, so that you can lower that local anesthetic down. And then talk to the mom. Talk to the mom. Tell the mom that it's gonna be okay, that it's gonna pass away, and then give her the nasal cannula, because sometimes if you put the belly mask, the more they panic. The more they're like, oh, I can't breathe, I can't breathe, I can't breathe. Right? So put the nasal cannula and like 6 liters. Higher pressure, higher partial pressure, the more you go in, right? So if it doesn't work, then by all means you need to intubate the patient, if you need to intubate the patient, right? That's the reason why we always advise you guys to have a general anesthetic setting when you do regional technique. This is really the culprit here. Once they feel that, they tend to panic, and the panic tends to be like, I can't breathe. They're not like that. They just say, I can't breathe. And well, so what's the other thing to determine whether you're sure you're going to be in the panic? Yeah, testing C6, right? C6, right? C6. Okay. High spinal. Does it happen? Yes. This is when you put your local anesthetic in. So you did a barbotage. You're like ching, 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 ching. And then you put the patient on his back, and you decide, oh, we're gonna do Trendelenburg, and all of a sudden it just went boom, way, way up, and then the patient is like, Tito, I really can't. So it always happens to nurses. Sorry. Or the wives or husbands of doctors or nurses, right? It was like, I can't breathe. What's going on? And you're like checking, and then of course it's even higher than C3, C5. So you're like, okay, well, let's talk about general anesthesia. So it does happen. It can go really, really very high. When it goes high, as always, KIC, everything. I know your OB doctor or whoever is going to be in the room is going to be kind of worried about the patient. You need to be in control of that case. If you need to intubate, then go ahead and intubate the patient, right? Go ahead and intubate. So if it's in the middle of a C-section case and you need to intubate, then go ahead and intubate the patient. If the baby is not out yet, right? If the baby is out, sometimes it's easy. If the baby is out, because you can ask the surgeon to numb the area, although they're still gonna feel some of those because they have to remove the placenta. You know how they remove the placenta and they go, one of the nurses will go on top of the mom here and they will like do this to push the placenta out because the incision is very tiny. So they're gonna feel, but they continue communicating with the patient. I only have 1 or 2 re-intubation because it was like, I can't help it, 3 o'clock in the morning already. I'm like, oh, let's go. And, you know, I extubated the patient before transferring the patient to the recovery room. Okay? And they shake, they shake very bad. Like, they shake so bad. It's not because they're cold. but because spinal anesthesia can impair the central thermoregulation, and then the patient, despite all the warming stuff that you're gonna give, they're gonna shake. Now, Zofran is a good drug that can be given prophylactically, which is good because we give it as a nausea and vomiting regimen, right? But if you give Zofran prophylactic around 4 to 8 milligrams, after you induce the patient with the spinal anesthesia, they're not gonna shake. So that's a good thing. But if you forget about that, because you always think of Zofran as just a drug for PUNP, then the patient is gonna shake. It's not gonna, so you just cover the patient, eventually the patient is gonna stop from shaking or shivering. This can be a patient dissatisfaction. So I recommend you guys, when you talk to them, to do informed consent, to make sure that they are aware that they might shake. Okay? They might shake. Okay, let's go to technique. And like I said, all of you are going to have individual kit and individual simulation lab experience. And I think I'm going to be dealing with all the distance sites, and the rest of you guys are going to be with the other faculty. But this is what we're going to do. So we always prepare and monitor the patient. So when we do our spinal anesthesia, you always have to have a blood pressure cuff. You need to have a pulse oximeter. You need to have your 12-lead EKG. I mean 12-lead, not 12-lead. The EKG, so either 3-lead or 5-lead. And you need to have your oxygen. Now, some organizations say, "Oh, we don't need oxygen." A lot of the hospitals that you're gonna go will require you to have an oxygen, at least 2 liters nasal cannula. So you need to prepare your drugs. So when I say prepare your drugs, remember I talked about preparing the neo and the ephedrine. So you prepare that ahead of time. But when I say prepare your drugs, that means you prepare your spinal kit. So I'm gonna show it to you guys. Always have a general anesthesia setup for the situations that I mentioned earlier. Assess the patient, determine what kind of surgery. So for spinal anesthesia, anything lower, right? We can't do surgery spinal over here, right? I guess we can, it's to go higher. But anything below T4, we can have surgery, so abdominal surgery done. Always determine whether they are on anticoagulants or antiplatelets, because you want to make sure those are discontinued before you even stick somebody in their bag. And then informed consent. Remember, patient refusal is 100% absolute contraindication. So if they don't want it, don't do it. But informed consent, make sure to tell them that there is a possibility of shivering. There is hypotension and bradycardia. Tell them also about the dural puncture headache. We're going to talk about that a couple of slides from now. If we finish, but if not, we're going to continue on Wednesday. So let them know. So that's informed consent. They need to know that we are expecting some of these events to happen. Because if they're going to have headache, they're going to complain. Guys, they're going to complain. And if you don't tell them, then they panic, something's wrong, he messed up, she messed up, I gotta complain, la la la, and all these things. And you don't want to be in that situation. You probably seen this last spring, but I added a couple because you're gonna be doing these cases. Remember we said T4 as our upper abdominal? I put in here, sometimes may require general anesthesia due to the vagal stimulation of the abdominal traction, celiac plexus, or if some of them push the baby out, because sometimes the baby doesn't come out if we're doing a C-section. So somebody goes on top and then they push the baby out. C-section is a good T4. Some hospital would say T6, so there is a variability. A lot of the hospitals would go T4. The reason why, it's because of the pushing of the upper abdomen to push the baby out. Why it's T8? testicles are embryonically derived from the same levels as the kidneys. So T8, remember T10, and I want to emphasize that. Okay. So T10, if you're going to have a knee surgery, and they're going to, so let's say right knee, and they're going to do a tourniquet, right, because they want to avoid bleeding. If there is a tourniquet, T10. I'm going to put that here, T10. Knee. Hip is also T10. This is lower leg or lower knee, L1 without a tourniquet. Are you getting it? Without tourniquet, L1. Okay? Okay. We're getting it. Types of needles. So, there is the one that's a quinky, which is a cutting needle. We rarely have that. Majority of our needles right now are either pencil tip or conical tip. Whitaker and Sprody needle. Okay, and then you can do your spinal anesthesia, or the patient can be in sitting position or a lateral position. Which do you think is easy? Sitting is easy. Lateral is hard. It requires a little bit of technique. So why am I emphasizing this, you guys? Position, position, position. So even though they're gonna hurry you up in the room, Brandon, let's go, let's start the case. You're putting the blood pressure, you're putting the pulse oximeter, you put the AKG, and then they let you sit, and they're like, hurry up, I'm gonna prepare your drug, you prep the patient. I don't care what they say. You have to position the patient appropriately. Because if they're just gonna stay there like this, it's not gonna happen. So you need to talk to the patient to route, and we're gonna talk about that. You have to help the patient position properly. Because if not, just like endotracheal intubation, the more attempt you have, the lesser chances of you getting it. Just like here, you have one attempt, the better. Second attempt is okay. The third and fourth attempt, you're going to be creating a lot of hematoma already, and you're going to be in trouble. So position the patient appropriately, okay? And this is, there is the nurse, because remember, you gave the patient what? Preoperatively? Was a drug that we like to give? Bedazolam, yeah, Versed. You gave the Versed, so you want somebody in front of the patient so that the patient doesn't fall off the bed, right? And then you do your 2 pierce line, remember? Feel the hip. L4 G. And then you mark, so if you have like a finger nails like me, ching ching, or if you want to do that thing, that's okay. You can do that. Okay? So you always tell the patient, like a Halloween cat, I think that's the common terminology. I'm from East Texas. Who's from Louisiana? Everybody from Louisiana. I would say like a shrimp. Position yourself like a cooked shrimp. Because the shrimp is like that, right? It's really, really round. So they always understand in my neck of the wood, right? Because they're like, oh yeah, I know. So they position. So Halloween cat, make your back look like a C. Cannonball. I like shrimp. And so every now and then I tilt the bed. So if I tilt the bed, so if the patient is sitting on the right side of the bed, I tilt the bed towards the left because the tendency is for that patient to avoid falling backward, right? So the more she tries to avoid, the more she goes like this. So the more I can see like, oh, I can see the, I don't do dark, but I can see the back. I can see the spinous processes. Okay, so Position. Lateral, like I said, is really hard. So what you do is the patient has to be like in a fetal position, on the lateral position. Sometimes we give them large pillows both in the leg and in the arm so that they can position like that. It's still hard. It's easy though to feel the iliac crest, but it's hard to start injecting the local anesthetics because it's hard to determine the midline. So you really need to have the bed in your height level, and the bed should be really straight. The problem sometimes with the bed is, remember, there are components of the bed. Sometimes it's a little higher and the lower, so that's the difficulty with lateral position. But it can be done. There are, okay, give me 10 minutes and we're going to continue next Wednesday. There are two approaches, median and paramedian. Median is the common approach. It's actually the easiest approach. Paramedian is a little hard because you go on the 15 degrees to the side. You really need to make sure you're going to center it to the ligamental flavum. And we're going to, when we do our simulation lab, we're going to teach you guys how to do paramedian. It's rarely done. The only time you do paramedian is when you have a patient who's scoliotic, right? So all the beauty pageants, just kidding. You have to go paramedian approach to get to the subarachnoid space. This is the median. So see here, he used his fingers instead of a marking pen. So I'm pretty sure he has a longer fingernails on the right thumb too, because that's what I usually do. I just and then you can see the fingernails in there. I think it doesn't hurt because nobody has said that it hurts. But L4. So remember, two-fierce line is L4. In your case, you go L4, L5. So you go a little space lower because that's where I want you guys to do it at this time. You can do L3, L2, L3, but next year, right? But this year, go lower than that L4 you have because the L4 is the body. So you go L4, L5. So you put your ching in there. So I don't know if you saw the video, but he's marking his fingernails there. And he wants to inject, so over here. He wants to inject, because you can't inject here, right? Because it's not going to go through, right? Okay, so you've seen the pretest. Okay. Unfortunately, you need to know this. I know. Because they're going to ask you that in the OR. What are the layers that you're going to traverse when you do a median approach? There's also what are the layers that you're going to traverse when you do a paramedian approach. If anybody has any mnemonics, please share. Okay, so all of this are the areas that you're going to traverse for your median technique. And this is how it is. So once the patient, you know where you target your injection sites, you prep it, and we're going to show you in the lab how to prep it. So when you prep it from the center and outer. You can't prep it from the outside to the center, right? You learned that in nursing school. So center, outer, you always have 3 of this. So make sure to use all 3 of them. So you put the betadine, unfortunately it's still a betadine, right? Betadine. Remember, heavy cleanse is better than betadine, right? But heavy cleanse is expensive. That's the reason why betadine is still here, and the kids still have betadine. That's the reason why, because betadine is not good for the CSF. That's the reason why you clean the area before you inject anything when you use betadine. So you open this one, you put it over here, and I don't know if you noticed there are 3 sponges. And this, so if you put the betadine here, you always soak it, and then you try to remove excess betadine in the sponge. So hopefully Wednesday I can bring it back here, and then we're going to show it. And then when you prep, instead of prepping like this, so instead of prepping like this, see like this. So what happens if you prep like this? The betadine that is in here is going to go to your gloves, right? Right? So it's not good, right? So when you prep it like this. I'm going to have the back here this Wednesday, and we can prep this. So when you prep it like this, so that when you squeeze this prep on the patient's skin, the betadine goes here, it doesn't go to your hand. Because the betadine is not good for your CSF. So there are 3 of them. Always use them. Okay? Always use them. And then you use this 4x4. I'm gonna get them back here this Wednesday. Use the 4x4 to clean it, and then mark the site again. The reason why I don't use the pen, because every time I use the pen and I prep, I lose the pen, the ink of the pen. That's the reason why I like to use my thumb with my longer fingernails. I'll just do that because I can see the X in there, like so. And then you numb. I'm going to show you that there are too many ways to numb the patient's skin. There are too many ways to numb the patient's skin. Like again, I'll show this to you if I can borrow a back this Wednesday. And then we're going to go with the process. You know what? It won't look good if I don't have a back in me today. Who wants to volunteer? Just kidding. You guys are tired. Whiskey? Tito's vodka? Just don't fall. Like hit your leg and you have like a ring around over here. It looks like you're skipping. Somebody fell. Like fell. Okay. Let's call it a day. We're gonna finish it Wednesday, and then hopefully we can get the back. The pre-test is just a pre-test. They're not part of the grade. You want me to open it again? Open it again. And I thank you that I saw. So chapter 56 is the correct chapter for the Miller. I'll open the pretest again. It just gives you an idea. That's how I'm gonna exam you. I mean, that's how I'm gonna write the exam. It didn't sound right. That's how I'm gonna write the exam. You guys know me already. I don't know if you noticed there is a pulmonary pressure volume loop in there. Right? So the correct answer would be restrictive lung disease, which would be letter D. D. Because it increases the spread. How many questions? I don't know. They haven't asked me. I have a lot. But I don't think so they're going to use a lot of mine. So, but I have a lot. So go home, get some whiskey. Or some oh, that's Spinal. Yeah.
I gotta use the restroom.
Yeah. Oh, you forget so some surgeons will give you surgery. Some surgeons will give so they want because the tourniquet is set at 20. So it's gonna be yes. So if you have a knee surgery and then you have a tourniquet and that knee, doesn't matter which knee, you're gonna go to 10 because if you just do it that your patient is gonna complain because they're awake. You might not take care of this one. Yeah. That's that. And so every now and then you're going to have to after. Most of the time, I would say 90% you're going to have to. The tourniquet is more painful than the sound. So you put it in, let's say you should put it in but say you put it in over under the patient, that number is going to travel in the same area. See,
You just do it.
It's still gonna travel. It's still gonna travel. Yeah. Oh, it's still gonna travel. It's gonna travel. Yeah. This is your isomersive. It's called my Well, yeah, because it those dependent in the sense that the time when it's gonna block that area. Oh, yeah. Because it's kind of like any long one that goes you'll eventually go there. Because no matter, you're still gonna, but it'll take a little longer. So you're still gonna go here. It's just a little longer. No, not C-section, you don't push. They don't push. Vaginal, so vaginal delivery, you rarely do small, and you do epidural in vaginal delivery. We lose smaller in spinal. Oh God, yeah, you do. In your epidural, you can lower the dose, and this one is still gonna, not all of it, but it's still gonna maintain. Like for example, so let's say we're just gonna use a 0.0625 that's what they came through your laboratory principle. Let's say you're running it at 10 cc or 12 cc an hour. Let's say 12 cc an hour. And then it's already time for second stage, right? Or they're about to push, right? It's dilated, the baby's down, it's about to push. What you could do is you could lower that from 12 cc to probably 6 cc. So that they're still going to have some analgesia associated with it, but the motor is much stronger. Majority of the labor the local anesthetics are called, I don't know if you heard the term mobile or walking epidural because of the concentration is too low. 0.025. It's not like 2%, like 2% or 0.5%. You don't go that high.
Let's see how this works.
They can be, but they may not be as bad as well. Because there's some epidurals that are solid. There are some epidurals that are really. So the idea is they're gonna go there. It's just gonna take a while.
Students earn their grades. It's not my problem. They earned a failed grade. That means they didn't study.
Okay, so
And then he said,
beer block is an IV block. It's not in the spine.
That's what.
Oh, yeah, yeah. Oh,
Yeah,
okay.
so we're just
Yeah.
teacher, I believe.
Okay.
It's studying. And I was like,
Is that in your
I was like,
research?
you can't tell me exactly.
Okay, yeah.
And if there's,
It's an IV.
you can tell me we all study.
There's no differential blockade and IV. The differential blockade is in the spine. Oh yeah, if you keep running like so Republican 0.0625 is and if you're running for let's say 12 hours, a number, the patient can. There's so many.
Hey, you're in consolidated.
And it took
That's the
me
reason why they will call us and say, hey, can you lower
these
those
magnets.
or turn it off?
Oh, before I figured out,
Because they're
I
still
can.
gonna,
Long story short is, for a while I thought I had to have my phone here in order to get everything integrated, but I can just use that. So
oh, yeah,
I can take I can take those off.
It's crazy, man. I feel for her.
Yeah. I don't know what to say or how much to say. He was expecting it. I wasn't.
Well, I was expecting it too for myself.
Oh, really? On the edge and whatnot.
They made concessions to keep a number of people in. I mean, I thought that it was enough concession to keep everyone in, but apparently not.
Yeah, I
Because
don't.
they changed the grading system from because remember they have the asterisks on all these classes for the starting semester.
Right,
So they
right.
dropped the asterisks.
Right.
So the only way to fill out after they dropped the asterisks for the semester was to either have 3 C's or technically D.
Nah, I didn't have 3 C's. Yeah. See, I don't know whether or not to tell him that. Would that make you feel
Well,
more
yeah,
singled out or what? I don't know.
Well, I mean, it depends on what he had.
Yeah, that's true.
I can't imagine that they would have, handpicked somebody to not go through if they still met the criteria.
I don't know. I'm pretty sure he had, because we shared grades off and on. Not every single one, and every grade, they're all B's. Yeah, high B's. Like 85. Yeah, I don't know. He did make a comment, and I don't know if he even remembers this, but he on tests he didn't do well. He met with some of the professors, and he did make a comment like, some of them very randomly said things like, "Oh, you've never done anything to offend me," and stuff like that. Like on more than one occasion. Like, and so he didn't say anything in the meeting, but afterwards he was just like, that was like a really random place to just interject that. Yeah. So that's the only thing I can think of, but which is really unfortunate.
Yeah,
That's
if that's
okay.
the case,
That's
it's
okay.
a
That's
pretty
okay.
unfortunate thing that they would hold standards for the program, but yet keep everyone together because of their personality or whatever.
Yeah.
It's not the way you should be running anything.
Yeah, I can't imagine that would be the case, but at the same time, all the facts aren't matching up. So I don't know. I don't know what to think. I don't know what to think. I don't know what to say.
Yeah.
It's really unfortunate.
I don't know.
Moving on though.
Yeah, we just gotta push forward, right?
All right.
Keep going.
See you, man.
Is that kind of how they want to use it?
Yeah, we will be inside there, there's all kind of.
And so she's like, come here, let's. So as a matter of fact, I messaged yes, I told the guy the needle because I don't know the sequence. So yeah, you get it.
It's pretty big, it's the same model.
What city? What part?